Well, thank you, Anne. Let me get my screen up. I want to actually talk to everybody about neuromodulation, and I am very interested in integrating it into practice and consider it so important for patients. And I thought what we ought to do is talk about all of the 5 FDA cleared non-invasive neuromodulation devices and their role in the treatment of migraine, review how they work, talk about the cost and how to use them, and then what we do when we integrate them in practice and for people, different patient types. And I will show a few cases to talk about this. What does it mean when we say non-invasive neuromodulation? Well, it means using a portable device which is placed on the body or head for a period of time. And the device can use vibration or electrical signals or a magnet. And that stimulation goes from outside the head into the brain and can alter brain pathways and reduce the pain of migraine. The 5 devices that are FDA cleared for migraine all work in an as needed way. They work acutely, and one can use them to treat a migraine episode and reduce or eliminate the migraine pain for that particular attack and the other migraine symptoms. So, sensitivity to light, sensitivity to noise, nausea at the time of a migraine attack. And what we've learned is that for all 5 devices, when used regularly, they can also prevent migraine, meaning that they can reduce the frequency and severity and length of migraine episodes. The FDA calls them non-significant risk devices. And that means they really do not have major side effects. So, from the standpoint of how to treat, these are really fantastic additions to our opportunity to take on migraine, in that they're not drugs. They don't have drug effects and they don't interact with drugs, and they can work both on an as needed acute basis and on a preventive basis, which is really great for patients. Let me talk about a patient, and that's always useful in terms of thinking about how we're going to use these devices. It's a 27-year-old woman. This is a real patient with disabling high frequency episodic migraine. What that means is that she's having migraine attacks 10, 14 days per month. 15 or more days is chronic migraine, but 10 to 14 days, everybody would agree, is a high frequency of migraine. And her doctors were giving her the usual older medicines. Amitriptyline made her too tired. Topiramate made her not think clearly. Propranolol made her lightheaded. And for acute treatment, for as needed treatment, she was given sumatriptan. They caused chest tightness. Rizatriptan made her sleepy. Zolmitriptan gave her nausea. Naratriptan was too slow and didn't work. And she tried Rimegepant, Nurtec, and she tried Ubrogepant, Ubrelvy, and they were too slow and they didn't really work. So she did not have very good preventive treatment. She did not have very good acute treatment. She didn't want to try lasmiditan because there's an 8-hour requirement not to drive after you use it for acute treatment. And she also told the providers that she is thinking about getting pregnant and she wants to stop contraception. So you add all that up, that's a challenge in terms of what's going on with the migraines. Now, what has changed is that we used to think about acute treatment, that's what people take when they get an attack, and preventive treatment to prevent the migraine, and those were considered separate. But now the wall has come down, and we have all of these treatments now that work both on an as needed basis and on a preventive basis. And all of the neuromodulation devices do that. They work both ways, which is very exciting. These are the 5 devices. And on the left, I just put them in the order in which they were approved or cleared by the FDA. The first device that was cleared by the FDA is called the external trigeminal stimulator, or Cephaly. The next one was the single pulse transcranial magnetic stimulator. So that's a magnet, STMS or Savvy Dual. The third one was a non-invasive vagal nerve stimulator, NVNS or Gamma Core. You can see it looks like a Norelco razor there, whereas the STMS goes on the back of the head and the Cephaly on the front of the head. The remote electrical neuromodulation device, REN or Nerivio, goes on the arm. It's turned on with a smartphone app. And then Relivion, which is sits very lightly on the head and stimulates in the front and the back. So combined occipital and trigeminal neurostimulator, Relivion. I'll take you through each one. This one is, as I said, is the first one that was approved, Cephaly, and it sits on the forehead with a magnet that attaches to a sticky pad. It was first approved for the prevention of migraine, where people would wear it on the forehead, turn it on for 20 minutes every night. And in the studies that led the FDA to clear it, there were more people. It was a sham-controlled device. A lot of these devices studied the device and then something that looked just like the device but didn't actually do the actual stimulation, called a sham device. And more people had at least a 50% drop in their migraine days with Cephaly than with sham, but it didn't actually reduce the monthly migraine days in the study that led the FDA to clear it. So it didn't actually reduce the frequency in everybody compared to the sham. And then Cephaly was studied on an as-needed treatment for the acute treatment of migraine, with a different program in which it would turn on for an hour. And that worked. It was also studied on an as-needed basis for 2 hours, and it's FDA cleared for the acute and preventive treatment of migraine in adults. And it works by sending a signal from the forehead through a nerve that goes into the brain called the trigeminal nerve to the lower part of the brain stem, where the migraine is processed. And it changes the way the brain receives the migraine pain signals. And it can be, and I have this backwards on this slide, but it can be set for the acute treatment for 1 to 2 hours, or the preventive treatment is 20 minutes. And for example, the patient has to wear it every night for 20 minutes, and the signal ramps up over the 20 minutes, gets more and more intense, or over the 1 to 2 hours if it's being used as needed. And it can be painful. It's one of the disadvantages of Cephaly. It can be very intense. Cephaly is a little different than the other 4 in that it can be ordered without a prescription. The second one that was approved is the single pulse magnetic stimulator, STMS or Savvy Dual. And this is this device that goes on the back of the head and sends a magnetic pulse in a split second to the back of the head, bang, like that. And the pulses work on the nerves of the brain and suppress the pain pathways. And a person could turn on several pulses in a row to stop an attack acutely, or they can do 4 pulses twice a day, every day, to prevent migraine over at least 3 months. It takes at least 3 months to work. So again, this device can be used preventively, and then people can do it as needed. And the maximum number of pulses that people can take per day is 17. Most patients don't have side effects when the magnet turns on. The magnet pulses don't really hurt. The acute treatment can work fast, but as I said, the preventive treatment, which is also the case with Cephaly, often takes at least 3 months to work. But when the pulse occurs, you can see that it's working at the back of the brain, and the magnet goes in and tries to turn the migraine off. The third device was the non-invasive vagal nerve stimulator, or Gamma Core Sapphire. And this is a portable device. As I said, it looks like an old Norelco razor, and it's put on the neck and activated for 2 minutes. It goes into the brain on a nerve called the vagus nerve. When it stimulates, the lip at the corner of the mouth on that side twitches. And the FDA cleared it for the as needed or acute treatment of an episode, 2 2-minute stimulations, and then wait 20 minutes and do 2 more stimulations, and then wait 2 hours, and if needed, do 2 more stimulations. So it can take quite a while to work. Preventively, it's FDA cleared to do 2 2-minute stimulations with the device 3 times a day, every day, and then gradually over months, see if there is prevention. The stimulation in the vagus goes up into the brain to stop the migraine. You have to put gel on those 2 metal electrodes that you see there before each stimulation cycle, so it can get pretty yucky. You got to keep replacing the gel. And interestingly, the studies on the device were actually not positive for what was sought, what's called the primary endpoint, but the overall studies showed benefit and there were no significant side effects. Some people did get an irritation on the side of the neck or in the throat, but the FDA did clear it both for the as needed acute treatment of migraine and the preventive treatment of migraine. The fourth device approved by the FDA was the remote electrical, cleared by the FDA, was the remote electrical neuromodulation device, or Nerivio. And this is a device that's placed on the arm and it's wrapped around the arm to stay in place and activated for 45 minutes by a smartphone app. It's a strong buzzing on the arms, not supposed to hurt. And the way it works is that for some reason, the discomfort in one location in the arm is supposed to inhibit the pain in the second location, which is the migraine. The protocol to use it acutely is you turn it on with the smartphone device for 45 minutes early in an attack to try to stop the migraine episode. And the protocol for the preventive treatment is to turn it on for 45 minutes every other day, and over months, the number of migraine days would go down. And it does work for people who have episodic migraine, less than 15 headache days per month, and chronic migraine, at least 15 headache days per month. And it did work within a couple of months of treatment for prevention. So it's a very reasonable device to try to use for both acute and preventive treatment. And the final device is the combined occipital trigeminal neurostimulator, Relivion MG. This got developed by engineers who really thought through what was going on with devices for migraine. And they actually talked to me at an international meeting about 6 years ago when they were planning to put this device together, and said that they wanted to create a device that would stimulate like cephaly in the front, but not hurt, and then have a way of getting in under the hair at the back where the occipital nerves go into the brain, and get an ability to stop the migraine from both directions. And we as headache doctors will sometimes do injections in the front, or injections in the front, and injections in the front or injections in the back to stop migraine. The idea would be that you would have a device where you wouldn't have to do injections and it wouldn't hurt, and it would combine the benefit going into the brain to stop the migraine from 2 different directions and 2 different routes. So I wrote here, this device was engineered to combine the occipital, that's the back area, and the cervical, that's the back area, and then the trigeminal at the front, to get an additive benefit, designed to not hurt. And multiple studies of the Relivion MG device compared with sham have been completed. All of them have been positive. When I was approached about this, I said, well, if you could make a cephaly that doesn't hurt and you could add in the back, you might get something which would be more powerful and would be really fantastic for patients. So I did participate in creating the studies for the Relivion MG. And the study that led the FDA to approve it was a use of the device for 60 minutes on an as needed basis to stop the attacks. You can see here on the diagram that it actually sits over 4 nerves in the front, 2 nerves in the back. It pops out so that so people can pop it on underneath the hair, very lightweight. And the study was very positive. It really worked well to stop the attacks. It really did suggest that coming in from both sides did have an additive benefit, and people did not have significant side effects. And to our surprise, the FDA cleared the device for the acute treatment of migraine 90 days after it was submitted to the FDA, which is really fast. They just basically said, look, the study is fine, works really well. Side effects are almost non-existent. We approve it. We clear it. And then it took over a year after the FDA had approved it for the full study to get published, because it took us a long time to write it up, and we didn't think the FDA would clear it so fast. So it was a very happy program, because the study was very well controlled. It was an international study. The results were great, and the FDA moved so quickly to make this Relivion MG available for people. And in the study, when people put it on, and to remember, they're trying to treat an attack of migraine, 60% got relief by 2 hours. 46% of people who used it were pain-free by 2 hours. Really, really high pain-free numbers by 2 hours, higher than with triptans. 70% of the people had the device work in at least half of 5 attacks and didn't require any medicine. So that was great. And over a third of the people were pain-free at 2 hours, and the headache did not come back, and they didn't use any rescue medicine over the next day. So that's called a sustained pain-free response. They got pain-free, and they didn't have any more headache, and they didn't have to take any drugs. And the effectiveness was so high that I thought that it's because it was coming in from both sides, that the additive effects were suggested by this. And as I said, there were no serious side effects with it. We also know that it looks like it works for migraine prevention. And the preventive trials are still underway, but there have been some studies that Dr. Roni Sharon has done. He practices in Brooklyn, and he also practices in Tel Aviv. And he evaluated how well this device would work. He had people try it for 20 minutes on, 5 to 7 days a week for 6 months. And over here, you see on the left that when they started, they were having about 15 migraine days per month. And by the end of the 6 months, they were having 5 migraine days per month. So it dropped by almost 2/3. And evaluating the percentage of people who had at least a 75% drop in their migraine days, you can see on the right, it was a very high number. It was over 80% of the patients had at least a 75% drop in their monthly migraine days. And this would be predicted by the fact that all of the other non-invasive neuromodulation devices work both acutely and preventively. Cephaly, which is the front one, and so the Relivion device does have some of the same effects as Cephaly. That works acutely and preventively. You're adding the back here, so you would anticipate it would work at least as well as Cephaly, if not better, without the discomfort that occurs when Cephaly is turned on. Therefore, I would say that in my practice, all 5 devices work both acutely as needed, preventively, and I can use any of them in practice to help people who don't want drugs. How do they work? Well, these devices all start on the outside of the head and then move into the head. So here's a brain, different areas of the brain up and down, and Cephaly at the front and Relivion MG at the front come in, as I said, on the trigeminal nerve, and that goes down to the bottom of the brain in an area called the trigeminal cervical complex, which is TCC here, and they inhibit the trigeminal cervical complex. And they both come in from the front, cephaly only from the front, Relivion front and back, so we'll show that. The gamma core device comes in on the 10th nerve. So it comes in on a different nerve, goes in and tries to turn off the migraine by going up along that blue pathway to the thalamus, which is the THAL there. Thalamus is the switching center for pain in the head. The STMS magnet comes in from the back. The gamma core, as I said, goes up to the thalamus, and both the magnet and the gamma core inhibit the switching center for pain in the thalamus. The Relivion, though, also comes in from the back through occipital nerve stimulation. So the Relivion has a double mechanism of action, coming in from the front and coming in from the back to terminate the migraine or prevent migraine. And finally, the Neurivio device, the one that goes on the arm, comes up into the brainstem by a reflex to turn off the migraine. But what I wrote up here on the left, from outside in, these are devices that activate and inhibit the brain, but from the outside going in. Most of the devices have very good studies, positive studies that are controlled with a sham. And what we're interested in as scientists is we want people to not be able to tell at the beginning whether they're getting the device or whether they're getting the sham. So we ask them at the end, did you think you had a sham or did you think you had the active treatment? The FDA wants to know that as well. And most people can't tell. In the magnet study, they got it wrong 80% of the time. In the Relivion MG study, they got it wrong 90% of the time. That means these were very good studies in terms of evaluating the effectiveness of the devices. And most of these studies were positive for what are called the primary endpoint. That is the reduction in the migraines that's predetermined, that we set in advance to make sure that the migraine is going to be stopped or prevented. Now let's talk a little bit about cost. This is a big issue because most of the commercial insurance is not paying for these devices. The VA does. I think the VA covers all of them now, but otherwise we have to have a discussion about whether a person can afford these. Cephaly costs about $400 one time, and then you own it. Monthly payments are available, but the sticky electrode that you put on the forehead to put the cephaly on, that wears out. And it costs $25 to replace 3 electrodes, and that is required every 2 or 3 months. So there's an ongoing $25 every 2 or 3 month cost. When you order a cephaly, there's a 90-day return policy, and it's the only one that does not require a prescription, can be ordered online. All of the remaining 4 do require a prescription, which your provider would need to send to the company. Neurivio costs essentially $50 for the first device, and this is the one that goes on the arm. And each one of the Neurivio devices has enough juice in it to treat 18 times, 18 stimulations of 45 minutes per stimulation. After trying it for the $50, it then costs $90 per device after that, or you can order 3 devices for $200. So that's $67 per device, but only for commercially insured patients. So that's the price of the Neurivio. Relivion allows for $200 for the first 3 months. There is an unlimited use, so it doesn't have the restriction that Neurivio has of only being able to treat 18 times. So one can really try it for the 3 months. And after that, it's $75 a month for unlimited use. And therefore, one could use their Relivion every night at the 20 minutes for prevention, and one could, which is not in the FDA clearance, and one can use it for 60 minutes to stop an attack, or set how long you want to use it try to terminate attacks, and there's not any limit on how often you use it. The gamma-core device, the non-invasive vagal nerve stimulator, at this point, it's $200 per month for unlimited use for both the acute and preventive treatments. There are some special deals at some centers, but most places it's $200 a month, so it's pretty pricey. And the most pricey of all is the STMS, the magnet, which is $350 per month to rent, and you're required to pay $1,000 and $1,050 upfront one time for 3 months, and that's without any special deals. So $1,050 for 3 months, and then if you like it, it's $350 per month to rent, and they use a SIM card for that. So there's quite a there's a lot of consideration about the cost when we decide which device we're going to use for people. The American Headache Society published 2 years ago support for the use of these devices. And their article, their consensus statement, stated that the effectiveness and safety of neuromodulation is supported by the positive results from the trials, and that neuromodulation is appropriate for both as needed acute or preventive treatment, and that the goal of using the neuromodulation device for acute and preventive treatment is the same. The goals are the same as you would do for a medicine. Terminate the migraine attack, and an as needed basis, prevent the migraine attack. And what Jessica Elani and colleagues wrote is that all patients with a confirmed diagnosis of migraine may be offered treatment with a neuromodulation device, which alters the pain mechanisms involved in the headache by stimulating the brain centrally or peripherally with an electric current or a magnetic field, and can be used alone or along with medication. This is how the American Headache Society sees the use, how we integrate the neuromodulation into our treatment. Somebody, for example, prefers non-drug treatment, or drug treatment has been tried and it's ineffective, or the side effects are too bad with the drug treatment, or somebody has medical illnesses that prevent drugs from being used, that contraindicate the drugs. You shouldn't be using those drugs for that particular kind of patient. There's a whole series of interlocking reasons why we would use neuromodulation. And in the American Headache Society article, they said patients who have an inadequate response to a migraine-specific medicine, that would be triptans, could be non-steroidal anti-inflammatories, ergots, gepants, lasmiditan, for whom multiple medicines have failed, either due to a lack of effectiveness or side effects, those would be good people to give neuromodulation to. Those who have frequent attacks and are taking more and more acute medicine and are developing more and more frequent headache, those would be people that would be really good to give neuromodulation instead of more drugs. There are a lot of people who prefer to avoid medicine, young people with low frequency of migraine who don't want medicine. Those who, as I said, who have contraindications to medicine, they can't take them for various reasons. For example, people with ulcer disease who can't take anti-inflammatories, or kidney disease can't take anti-inflammatories, or blood vessel disease can't take triptans. Adding on to existing medicine. There's no reason why you can't add neuromodulation to existing medicines. There are tech savvy people who want to embrace new technology, neuromodulation, great. Those who are planning pregnancy, because you can simply stop it and there's no time that they stick around, so they can be quickly stopped if somebody gets pregnant. Those who are taking a lot of medicines and there's worry about how those medicines have interactions, drug-drug interactions. Again, neuromodulation, perfect for that. And even at the other end, when people have tried a lot of medicines and those medicines have failed, they will sometimes work beautifully. Neuromodulation will work beautifully in people for whom medicines have failed, because when you give a medicine, you're aiming at a particular chemical target But when you use neuromodulation, you're altering the brain and the targets that you know about and the targets that you don't know about. Now, the commercial payers refuse to pay for these, and nothing gets me more angry about it. I think it's just a terrible, terrible shame that that our insurance payers are refusing to pay, and they say a lot of things that are not true. They say there's poor quality of data. I showed you that's not the case. They say that because the FDA clears these devices, that's not the same as approval for a drug, but that is no reason not to cover them. They say there's no outcome data. That is, that we don't know how people do with them, but there are thousands of patients that have been reported now who have used these devices and have published their results. They say the devices are experimental. That's obviously not true. They're already FDA cleared. Some of the insurance have what's called a pharmacy benefit and a medical benefit. And so each side of the insurance says, you pay for it, we're not going to pay for it. And they say there's no demand for the devices, and that's clearly not true. And they say that the professional organizations don't suggest that they should be used. And I just showed you the American Headache Society saying they should be used. So I think these are excuses, and I think our payers should be ashamed of themselves, and we need to demand that we be allowed to use them as patients and provide them as providers. Getting back to our patient, she had numerous preventive medicines. I showed you that. Numerous acute medicines had failed. She's considering getting pregnant. She's a perfect candidate for neuromodulation. She has 10 to 14 headache days a month. She can use neuromodulation for both preventive and acute indications, preferably a device that does both. Somebody trying to get pregnant, I tend not to use the vagal nerve stimulator, the gamma core, but any of the other four, the Savvy, the Magnet, Neurivio, Relivion MG, they're all perfect for her. They won't cause side effects. They can be used as needed and preventively, and they can be stopped if she decides to get pregnant or is pregnant. So just to remind you, the FDA cleared devices, there's 5. Cephaly, one at the front, Savvy, the Magnet, Gamma Core on the neck, Neurivio on the arm, and Relivion MG front and back. And for this patient, I recommended one of those 4, Cephaly, Savvy, Neurivio, or Relivion MG. And we, as providers, are currently integrating these devices into our practice every day. Every day we recommend them for patients because they are well tolerated, because they're safe, because they work, because the data on them have been fantastic. And we just need to advocate. We need to advocate for payer access because the cost and the access continues to be, both of them continue to be challenges and prevent people from getting their hands on these when they can be so helpful in controlling migraine. So I will thank you, and I will take a look at what we've got in the chat. Let's take a look at some questions we've got. The VA, it says, currently covers all except Relivion MG. That's not yet approved in the VA. But this patient who wrote in said he just received his gamma core device from the VA. And he did specifically request Relivion MG because it was recommended by headache specialists at Georgetown, which is where Jessica Elani is, but the VA said it was not in the formulary yet. So that's something that I should talk to the VA about next week. Another question is, does neuromodulation work for hypnic headaches? Hypnic headaches are a rare form of headache that occur in the elderly, in which they get attacks of headache in the middle of the night for no apparent reason, most nights, and they've not been tried for hypnic headache. None of these devices have been tried for hypnic headache. There's not been anything published on them. So the answer is we don't know. And I think because they don't have significant risk, it's well worth trying them for hypnic headache. The question that was raised, have the Relivion MG ironed out early issues with their very first device? And at the very beginning of the pivotal trial for Relivion MG, there were some problems with the device in terms of the manufacturer and that has been completely resolved. It was resolved really by the end of the trial, actually by the middle of the trial, and so the FDA then approved it very rapidly based on the very strong results of the trial, which was fully published. So there have not been any technical issues with this device for many, many years, which is really good news. Let me see if we have any more questions here. Can Relivion be effective for occipital neuralgia? It's a really wonderful question. The reason is because the Relivion works occipitally as well as in the front. So for occipital neuralgia, what headache specialists usually do is to give injections of lidocaine in the back where the pain is in occipital neuralgia. And the question would be, would a device that stimulates back there and inhibits work the same as the injections? And the answer is we don't know. Hasn't been tried. Again, I think it's worth studying because there's not a lot of risk, and it really should work. But that's just my personal opinion. It's not in the FDA clearance, and there have not been any formal studies of Relivion MG for occipital neuralgia. The next question was about the price of Relivion MG, and I don't know what it was originally, but I showed you what the price is now. Another person from Seattle has had migraine for 28 years, and he's tried the Relivion MG, is on a couple of weeks, and he says that the product is well made and the training was done very well. And when would you see results? Well, that's a very good question. I showed you the data from Roni Sharon. He had people using it 5 to 7 days per week for 20 minutes per day and evaluated after 6 months. That's when you saw these pretty dramatic drops in migraine frequency. And for most of the devices, 3 months is when you start to see the benefit in prevention. For acute treatment, you can often see it a lot earlier, as long as you treat early in the attacks. But I always counsel my patients, it can take time with neuromodulation. You're modulating the brain, so hang in there. And in the case of the Relivion MG and the prevention, before I give it for prevention to my patients, I say to them, I want you to hang in there for 6 months, because those are the numbers that we have from Dr. Sharon's work, and he looked at it at 6 months. So I would recommend continuing to use the 20 minutes nightly for prevention for 6 months, and then trying the 60 minutes for the acute treatment. Another patient wrote in, I love my Relivion MG. I also suffer from depression as part of my migraine and understand there's a Relivion unit specific for depression. Is there another protocol I can use my MG unit for depression? We don't know yet what is going to happen with depression, but the Relivion device is being studied for depression. And in fact, the company submitted to the FDA a request based on their preliminary studies of Relivion for depression for what is called a breakthrough device designation. It's a very coveted award, which suggests that your device is going to be useful for a particular disorder that's very disabling and for which there's great need. And they were awarded a breakthrough device designation for Relivion for depression. Now, the next step is they have to complete the depression studies, and that will tell us what kind of stimulation is needed and for how long, as long as it's positive. But it is a very exciting prospect that this could work in both areas, and it's something that I want to talk to the VA about, because it is so common to have both depression and migraine in the same person. And it would be wonderful if we could be treating both disorders with something that's so benign. So that's a really interesting area for the future. I'm not seeing any more questions, so I want to thank you all for having joined me today. It was very, very exciting for me to be able to talk to you about neuromodulation and the way that we anticipate, the way that we do use it in practice, and the way that we hope to use it more in practice if we can get our payers to pony up and recognize that this is something that is needed and important and useful and effective and safe and tolerable. So I hate to be on a soapbox about it, but I really think we need to keep the pressure on. I would like to turn it back to Ann Fields to, oh wait, we may have one more question before I do that. Hang on one sec. A patient wrote in, so in other words, the stimulation might be different for depression. I don't think we know yet. It could be that there be a different protocol for depression, and we'll see what the studies yield as far as the indication for depression. So now I will turn it back to Ann Fields. Ann, are you there?
Sorry about that. I couldn't unmute at first. I'll turn it over to Raji for conclusions and next steps.
Yeah.
Thank you very much.
Thank you, Dr. Tepper.
Thank you, Dr. Tepper. And once again, for everybody that attended, thank you for spending the time. As I mentioned, we will be sharing this recording, so be on the lookout with our email as well as social media. And we will be holding more of these once per month. So again, thank you, for being a part of the Relivion DocTalk. Again, Dr. Tepper, thank you for your time. And we'll see you guys at the next one. Thank you.